huge pleasure to speak about very interesting modern technology and modern software. It's definitely, probably, for me personally, probably it will be one of the big discoveries for the last 5 years. Probably one of the biggest. One of the biggest. Let's say old idea with fantastic new application. Absolutely by purpose, my presentation will be really introductive, not in very informative, but nevertheless, you see, what about the brief history? In fact, as you can see, the brief history of thermography idea is not so brief. So it's starting from long time ago, since many years, the idea regarding the connection between temperature change and diseases. All kinds of diseases. Diseases not only of a particular part of the body, but diseases as a process. So every pathological process in the human body is leading to temperature change by inflammation, perfusion change, and so on. They are very much mechanisms. But during the time there were some obstacles. This initial idea to use the thermography as one of the signs of a disease to be applied into the daily practice. Regarding breast cancer, in fact, this is the first territory by historical point of view. The breast cancer was the first one with definitely data regarding the role of the thermography of some more participants. Okay, regarding the confirmation of breast cancer, and you probably don't know, but in fact, since 5 years, the thermography is into the American guidelines as one of the screening tool, very handy screening tool for breast cancer. And when we are speaking about different fields of application, of course, as a cardiologist, I have thought immediately about cardiovascular diseases. And there are some small publications regarding this application, but probably the heart itself as an organ, it's still a part of this application, but probably in the future even the heart will be. And the vascular diseases, it was absolutely logic to think about thermography and vascular diseases screening and diagnosis. Why? Because all vascular surgeons, all angiologists, all vascular specialists know that the vascular changes, both venous and arterial vascular changes, are leading to surface temperature change. So what we can feel with our hand, we can show it by thermography. And I mentioned already that the idea about the application of thermography in vascular pathology is since about the 60s of the past century. But unfortunately, because of the not so good, let's say, imaging, because of the resolution, not so perfect resolution, and for many artifacts, there are only very small series showing the role of thermography to show the vascular pathology and to show the result after the treatment. And there are several small publications. I'm showing several of them coming before our technology. And in fact, these small publications, in fact, increased our enthusiasm regarding the development of a method that can be applied on a different level of the medicine. Exactly, we are going to speak about the vascular medicine, but I'm absolutely convinced that this technology with the artificial intelligence applied by Kelvin Health will be available and will be one of the methods to show different and very categorically pathology. And thank you very much for your attention. And, it's very important to mention that we have in the panel two extremely experienced vascular specialists, vascular experts. Both of them are cardiologists and angiologists. I myself, I'm the same way. And also in our cardiology community, there are the combination of vascular and cardiology knowledge. And this alliance is very logical because the vascular system is one and the same. On the level of the heart, on the level of the brain, on the level of the peripheral vascular circulation, this is the same vascular system, and unfortunately the vascular diseases are systemic because the process of inflammation and atherosclerosis is systemic. There is no vascular territory that is protected, that is apart. No, all the vascular system is one and the same unit in the human body. And probably Dr. Tsonev and Professor Stankov, Docent Tsonev and Professor Stankov, they can tell some words. Professor Stankov.
It's a good pleasure for me to take part in this symposium. I'm Professor Stankov, I'm from the hospital. I'm head of angiology department. Professor Petrov told that I have three specialists, internal disease, cardiology and angiology. And now I work usually angiology and cardiology. I think that it's very nice because that told Professor Petrov, vascular system, the same in the whole body. Its method, thermography, is a very good method for screening, but now we start get data for this, and I think that after 1 to 2 years we will be told that it's very nice for screening for general practitioner doctors, for screening peripheral artery disease, and for follow-up after procedure. Thank you.
Associate Professor Tsonev from University Hospital Alexandrovska, and first of all I want to thank Professor Petrov to be involved in this project, and it's very honored also with Professor Stankov. I know that Professor Petrov is always an innovator, so I was very keen on trying to do something new, maybe old, but in a new way, as you told. So I also believe that this kind of screening is going to help us to find these 300,000 patients with peripheral artery diseases that we undertreat in Bulgaria. So I believe in this method, and also to mention that we are not speaking only about thermography. We're speaking about artificial intelligence. So thank you.
Thank you, Professor Tsonev. Absolutely. Probably you know that September is the month of the peripheral vascular disease as a European initiative. So, and 29th of September is the Day of the Heart. So we are just on the target with all these presentations. And I will give the floor to Georgi in order to listen, to hear more about the artificial intelligence put together with the thermography as a method. What can show? Thank you.
Thank you very much for the introduction. Thank you very much, Professor Petrov, for the great presentation and introduction to thermography. So let me open the presentation that I'm going to show you today. So essentially old but with new methods, that's a very good quote. I'm going to be talking about how thermography coupled with AI can essentially be created to save millions of lives today. My name is Kostadinov. I'm co-founder and CTO of Kelvin Health, and I'll be happy to present you in the next 15 minutes about this topic. So this is the scope of the presentation, starting with introduction to what we do, our mission, our team, which is currently the whole team in this room for the first time in, I don't know, several months, I believe, because Chris is living in South Korea. Then I'm going to cover an introduction to the pandemic called the PAT pandemic. Then I'm going to cover thermography AI solution, how thermography is coupled with AI essentially, a demonstration of this solution, its value and benefits to the clinical care, and I'm going to end this presentation with some references and real-world examples from our practice. So starting off with our mission, essentially our mission is to make preventable deaths and suffering from PAD and COI, I think in the past, by coupling thermography, AI, medical science into one discipline essentially, into creating one single product that can early detect all kinds of different anomalies and vascular changes that can be prevented. And by doing this, I mean, this is the team behind all of this idea. We have assembled a great team of medical experts, great medical experts, AI experts, business experts, and we have all the necessary tools and expertise to pull this off. In terms of AI expertise, I can say that we are in the field since 2012. We have developed hundreds, even thousands of algorithms for extracting all kinds of visual information, visual concepts from images, from videos. And we extract such information to create value to our customers that essentially creates a positive value to their end users. So let's talk about the PAD pandemic. I'm sure that most of you know how large scale this medical condition is, but still let me put some numbers on the table. First of all, there are over 200 million people worldwide that are affected by this disease. And due to the fact that it's really hard to diagnose in the early stages of the disease, most of them actually, the condition worsens and to the point of having COI, which affects 22 million people each year. And out of these, 60 to 70% are having at some point in time amputation, unfortunately. For diabetes, patients with diabetes, this number, there is 7 times more likely a chance to have an amputation, which is quite unfortunate. In terms of the healthcare system, as we know, there is high patient demand, but there's lack of specialists worldwide. And moreover, and most importantly, there's a lack of reliable, rapid, and precise and non-invasive methods that can easily detect PAD and give insights to the specialist to understand what should be the next step for treating this patient. And based on these two factors, there's a very low throughput of diagnosing PAD, which leads to very late intervention and very late treatment of such patients. And with Kelvin, we are trying to solve all these challenges, all these problems, by combining thermography, by combining medical science and the artificial intelligence, of course. So we're using Fluorman 1 Pro model thermal camera, and we're coupling it with the mobile phone currently to take 5 photos of the legs from different angles, and then analyze these photos using artificial intelligence, proprietary artificial intelligence algorithm that essentially, after the analysis, it tells the specialist what is the actual condition based on thermodynamics of the patient. We have created for this purpose a data collection platform that is for the review of all the data that has been collected using the mobile phone and this camera. And using this platform, the specialists can gain additional insights on the data that they have collected. And moreover, it's of course encrypted, secure, based on all of the HIPAA and GDPR compliance regulation frameworks. And at some point in the future, once we have developed all the AI algorithms, they will provide the insights as part of this platform. The mobile application, the unique thing about it is that we have created a proprietary segmentation algorithm that essentially is able to segment very, in a contrast and clear way, the problem, the issues within the vascular system. So for this, we have created algorithm, thermal segmentation algorithm, and specialists, while using the application and while using this algorithm, have told us that it's much clearer for them to see where the problem is in the vascular system than using, for example, standard Fluor 1 Pro applications. And the next slide is all about the AI and how the AI analysis works. Of course, our words don't allow us to share more details here. But essentially, the way that we do it is by combining all the 5 angles into a single spatial temporal space and analyzing them to gain insights of what is the actual condition of the patient at the moment. The way that the AI technology works is by training it on a large-scale database that we are currently collecting with partners in the field. And this large-scale database, essentially the way that's being learned from it is by extracting what is the most common pattern among them that correlates to this specific pathology of PAT and COI. So essentially we are creating a statistical model, and once the model is done, complete, then when new data comes in and is being analyzed, it essentially tries to see whether this new data fits within the model, and if it doesn't fit, what is the actual discrepancy that has been detected. So what is the difference that it has been detected? Essentially what we do, as seen from the slide, is we segment all the angiosomes of the legs, as you can see, and for each angiosome we provide a risk assessment, risk score, whether or not it's PAD or COI is visible. But why does it work? Actually, Professor Petrov covered that briefly. Essentially, there are 4 main reasons why thermography works, and coupled especially with AI algorithms. The first one is inflammation from viral infections where local body temperature is increased. The second one is metabolism, where we have very local increase of blood flow, oxygen, and thus temperature. The third and the fourth, spasm and blockage, are related to lower amount of blood flow in local regions, and especially the fourth one is directly correlated to PAD and COI, which essentially mean that there is some kind of a blockage or stenosis within this local region. And here's an example of how this actually looks like. So as you can see from the image, at the knee level there's I believe thrombosis. Dr. Stankov may share more details about that later on. But essentially, this directly correlates, the thermal image directly correlates with the actual diagnosis done via angiography, because from the angiography images you can see that just right at this knee level there is lower blood flow. So some demonstration that I'm going to show you how the actual method is used within clinical practice. As you can see, the specialist takes 5 photos of the legs from different angles. Then these photos are sent for analysis, and the platform using the AI algorithm suggests essentially for each angiosome what is the risk assessment. And as you can see, the angiosomes have been detected, and for each angiosome has suggested scoring based on a scoring system that we've created with the team of Professor Petrov and Dr. Stankov. This scoring system suggests whether there is stenosis or thrombosis within this particular angiosome. And what is the value and the benefits of having such a device within the clinical practice? So first of all, we sit right in the middle, right after the patient visit and right before the actual angiography and intervention. What we are able to do is to optimize the whole process of initial diagnosis by essentially providing a very fast approach for triage that is able to very easily and accurately give insights to the specialist whether or not the patient should go for angiography or whether or not the patient should go home, essentially. And all of that eliminates all of the unnecessary costs involved with angiography and with the diagnosis of PAD that we have calculated is up to 38% for HCPs around the world. This method as well also is very fast, as mentioned. It's 15 to 36 times faster, which can lead to much faster diagnosis by the specialist. And of course, last but not least, it provides real-time monitoring during the intervention as part of the catheterization labs, which is something that is not seen elsewhere with other devices currently. And some references. Currently, we have collected over 2,000 thermal images from 300 patients. And based on these images and data, we have preliminary results of 97.7 specificity. Of course, this is preliminary. We are currently in the process of validating that with more patients, with more data. This data will also be valuable for training the algorithm, so creating the final product, and of course for medically certifying the whole solution. Some examples, but Dr. Stankov will cover them in a much medically great detail. So currently you can see that there's an aorta blockage here for this patient, and it's directly correlated with the thermal image. Ischemia on the fingers is also quite easily visible, as you can see. That's a hand with ischemia, and you can see how the fingers are out of the range of the thermal palette. And after vascularization, everything has normalized in the fingers. Pre-stroke imbalance detection, you can see the differences, the cold spot on the left side, and after that, the stenting, how everything went back to normal. Some other use cases that I wanted to mention. Breast cancer is one of our other use cases that we are currently working with Novartis Oncology to essentially identify and to see what is the scope of the technology there. Rheumatoid arthritis, it's really important to have early detection of such disease there. In traumatology, such a solution can be used to localize the trauma and to to be much easily diagnosed when, especially, the patient is unconscious. And for COVID-19 monitoring, this was actually one of our first use cases that we essentially evaluated, and we saw that there is a direct correlation with viral infection and with what's shown on the thermal camera. So as you can see, there are quite a high variety of use cases that thermal cameras can be applied, and especially thermal cameras coupled with AI. So we believe that if we join forces and together we can help prevent the suffering and the effects that such conditions such as PAD, breast cancer, rheumatoid, any type of conditions can have on patients worldwide. Thank you very much for your attention.
Thank you for your presentation, very interesting presentation. Next presentation, Associate Professor Tsonev, collection and annotation of thermographic data to gold standards in daily angiology practice. The floor is yours.
Thank you. After these great results, I have nothing to say. So we are speaking about application of new technology into the clinical practice. Briefly, I will try to show some case and to add additional information and additional value of this system. I will start with one case just to visualize how complex peripheral artery disease patients. We have a lot of risk factors, a lot of comorbidities, a lot of different conditions that change into the time. So we have to first to measure, afterwards to diagnose, and afterwards to follow up. So a lot of information. This one patient from last week, you see we have the very new machine also for pulse wave velocity, and this is also a patient with Leriche syndrome. And we applied, we've done a procedure with Professor Vasilyev in this patient, and with great result. But what happens after this in these high-risk patients, it's a question of follow-up. That's why I believe that this new technology is going to be very useful in our patients. Sometimes our medical office looks like this. It's a quiet mess. It's a quiet mess not only of machines, but it's quite mess of different information that we have to put together to be sure that we assess the patient in a proper way and follow up the patient in a very proper way. What is the decision? What could we do in such a situation? Importance of data collection. How we take the information, how we classify the information, and afterwards, do we use this information, or we are like Plushkin, who just get something and don't use it? In recent centuries, we could say that going from the 1986, from the analog stage in the centuries, afterwards after 2000, we go to digital data, and nowadays we almost use everything in digital format. But how we use it and what is the importance of this? Information should be get from different sources. So we use analog sources, we use digital sources, but we have to put it together into one main aim for our patients. That's why what are the machines that could help us. As a cardiologist, I could mention here that now we have echo machines that also have artificial intelligences, but now we make the first steps into this. What is the aim? The aim is the top priority for the health system to be informed what happens with the single patients, what happens with a pool of patients, and that's why it's very important to collect the information in proper way and to analyze it and to use it. As I told you, the information could be in quantitative, in form of numbers, percentage, comparison, and etc., but qualitative also information. Some words, some colors, in our case. This is a nice old but gold publication that shows how we change our clinical practice and our thinking, and what is the time-consuming processes into our practice. You see nowadays that when we go from paper-based collection of information to computer-based collection of information, in several times we shorten the time for collecting, analyzing, and using the data. I hope it means also in Bulgaria, because once one administrative lady told me, as I use a computer, I have twice more paper. And you see that what is the final result? Do we spend more cost about this? As much we use the optimization, the computers, the process is going to be much more less expensive. So we also have value in this case. And what is a big data? We are talking about big data, and I think that our field in cardiovascular medicine is a very nice example for collecting a big data. So there is a couple of main characteristics. This is the volume. So we get a lot of information, but what is the velocity? Velocity of the getting information, analyzing, and getting back the information when you need it. And of course, what kind of varieties we use, analog, digital, categories, and so on and so on. I put this picture to not to speak about artificial intelligence, because Georgi was very detailed. And here now a very, very nice publication also, how we, the medical professionals, refer the information. Sometimes we put a lot of paper into our offices and we never have time to take the paper and to see, oh, this patient, I know I have somewhere the medical history, I will go refer, but some other day, and the day never comes. But if you have the information on your computer, if you have the information into your cellular phone, this is going to be very, very important. And you see that the more than half of the information is used when it's transactional data. When you get the information from there and you could give your opinion and go on with the computer. Purely was very detailed, and Professor Petrov has a great lecture about the concept of the machine. I have one complaining, I don't use iPhone, but I'll buy one. Okay, and this is the profile, you already saw it in private. This is the very friend user menu. Here you see, this is my profile on the profile, thermal camera and the patient. So in any time I could check the patient, I could add the patient, I could edit some information about the patient. So here we are not speaking only about thermography, but also adding more and more valuable information in our patients. This is the same patient with Leriche syndrome. After some kind of revascularization, you could see the difference into both legs on the left. This is the first stage revascularization. He has stage thrombosis also downstairs to the femoral part. Also, you could go to the patient menu on your computer and you could check if there is some X-ray, CT, MRI, and to get the information and to refer what happens with this patient and what could I do more for my patient to follow up. This is the menu. In any time you see when you examine the patient, when you follow up, and so on and so on. And here you see that the cleverest things are the simple things. So if I could put my phone into the room of the patient and just click, there is a hypertension, coronary vessel disease, chronic kidney disease, history of smoking, what is the profile of the patient. This is very, very valuable information that afterwards several parameters could be analyzed and to have a real register. So I think this is going to change our thinking, and in Bulgaria we suffer from lack of registers. And I believe these platforms are going to help us also. And to make one parallel into autonomous cars, I don't believe in them in 100%, but this is the future. And you see, you take source 1, source 2, source n, and the intelligence system is going to analyze it and to give our proper direction. Thank you for your attention.
Congratulations for very interesting presentation. And the next presentation, Dr. Stankov, medically specialized and fully automatic high-resolution thermography for patients with complex vascular pathology and their blood and vascular treatment.
Thank you. Now we see everything for thermography and what can do in our practice, but let us see in the real world, in the real practice, what do it. I start with one patient, with young patient with critical stenosis of right carotid artery, with arterial hypertension, dyslipidemia, risk factors for atherosclerosis, smoker, male, and history for cerebrovascular disease. From the echo Doppler, the standard for the peripheral artery disease investigation, we see 19% stenosis of the internal right carotid artery. This is the Doppler, and I present this case because after the more of 30 patients with analyzed with peripheral artery disease, we want to see, we can see the difference in the temperature in the brain. And when we see this on the thermography, and say amazing, we see from the cerebral angio, we see the zone of the cerebri media with low flow TC2, and anterior it's with contralateral flow from the left. And on the thermal camera, we see this different of the temperature in the brain. This is the recanalization, and this is after recanalization. We see the normal temperature of the treated zone. We started after that to do thermography for the whole zone, all patients with peripheral artery disease. And this is the one of the patient with critical ischemia of the right hand, and with previous 4 intervention, but with still subtotal stenosis of the brachial artery, radial artery, and ulnar artery. We see the finger of the thermal camera, we not see. It's with critical ischemia. And after recanalization and stent implantation of the right radial artery, we see on the thermography this result. It's amazing. And one patient of the practice with the peripheral artery disease, critical ischemia of the right side, with the occlusion of the popliteal artery and tibial artery. This is the Doppler standard procedure. From the angio, we see this occlusion with collateral flow on the distal part on the tibial artery, posterior tibial artery. This after recanalization of the popliteal artery and the peronea and tibial posterior artery. I take this patient because it's very important to see the zone of the anterior artery. It's still with low temperature. We see the angiozone of the tibial posterior artery. It's with very good temperature. For the conclusion, thermography is the safe, available, and effective method in the diagnosis and of peripheral vascular disease in all vascular areas. Thermography could be used both for the patient screening and for diagnosis and post-treatment follow-up. Future randomized clinical trials need to prove its role in modern medicine. Thank you.
I don't know if you need microphone, but it's you probably saw what it was the wow effect after the first several images that we have done. And I just commented with Professor Tsonev that for the carotid territory, it's done for the first time in the world. So it was our idea to check. In fact, the first carotid critical stenosis was the first one to raise in my hand the question, but it's really a critical stenosis. It's probably in case, despite there is a skull, so we have here bones, and it's not direct relationship between the inner part of the circulation and the surface. But nevertheless, we decided to check. And after making the picture before and after the intervention, it's really amazing. I'm dreaming, since the first moment I'm dreaming that in every single stroke department and stroke ambulance, we know that, for example, in German-speaking Europe, they are since 10 years, they are stroke-intended ambulances. So it's so simple to make in 3 seconds a picture of the skull of a patient and to decide if it's ischemia or it's a hemorrhage or it's something else. So probably this will be in the future, but we are going to publish these several cases, and it was absolutely continuous data. It was a repetition of the same from the first one. So we have the confirmation in more than 20 carotid cases nowadays. And you probably saw the Leriche that Georgi have shown the patient with Leriche syndrome, occlusion of the aorta. And even non-specialists will realize immediately that there is something wrong with the perfusion of the legs. So it's, you know very well the aphorism that one picture is telling more than 1,000 words. So this is put together with the artificial intelligence, it's really impressive. What is your opinion? Comments? Anna?
Very exciting. I just was sitting here all the presentation. I've got thousands of questions. It's really, really exciting to look at it. First of all, I was curious, how much does it take time for processing? So between you take the picture and there is a report or outcome, how much time does it take?
Immediate.
Absolutely. So within several seconds, essentially, because we have quite an extensive expertise in real-time AI processing, and actually we are very, how can I say, without showing off. So essentially, we can process everything in a matter of several seconds. So the result will be immediately at the screen of the specialist when he takes the pictures of the patient.
There's no others. I'm good at words. So I was very worried about the iPhone comment. Is it only for iPhone-based devices? Because I understand that you attach it to the phone. And when is Android version?
Yeah, so essentially, little spoilers, we are currently developing a proprietary thermographic camera with a partner from here in Bulgaria, which will be much larger in size, but even more precise and specialized for the thermodynamics of the body. So it will not use any iPhones or mobile phones at all, it will be directly connected to the specialist computer.
Oh, and that. I know that you mentioned that you're taking different angles of the legs that we were seeing on the screen. Do you have like a template of what you take and how you ensure that it's the same angle, you know, the reproducibility of the angle? How did you overcome this problem?
Yeah, very good question. Actually, currently we don't have this template, but it's under development. In the meantime, we have developed an algorithm that essentially maps all the images within a single template. So we're too lazy, and that's why we built an algorithm to automatically make all the images unified and uniform. But at some point, when we especially have this thermal hardware, specialized thermal hardware, it will have a template, it will have guidelines in terms of the angle, in terms of the distance, where to shoot the patient from, and everything will be controlled via the software. So in other words, the software will tell you, okay, the patient is too far, the patient is from this angle, but you should be from the other angle, you should put the patient within this template, and so it's, yeah, it will be something definitely in the future.
The last question, because I know it's progress, I will catch you later anyway. So I know that you're developing the algorithm. So when we assume that it reaches the clinical stage and then we'll start to the clinical stage, will this new clinical images be feedback to the algorithm, and will the algorithm be learning on those new clinical cases, or is it the done deal when it's released?
Yeah, it depends on the regulatory framework. In our opinion, it should be improved over time, but this depends how FDA will allow us to do that, and CE mark, of course, CE notifying bodies will allow us to do that, because essentially AI algorithms currently, as defined by the regulatory framework, are fixed models. So once you validate the model, you essentially cannot improve it, at least based on our preliminary information about that. But we believe this will change in the near future, because more and more AI algorithms in the healthcare industry are developed, and it will be a much, it will be essentially everything will be off the shelf, and the framework will need to change.
If you allow me a small comment, in fact, the surgeon's hand is not regulated and it's not approved, but it's used and it's giving us clinical data. And this is the same way. Seeing a wound, we know that the patient has a problem, most probably vascular. And the thermography is proving, is it vascular or not? I'm sure that in your practice, guys, all of you have a lot of patients going to neurologist, orthopedist, skin disorder physician, and finally somebody has a strange idea, decide to put his hand on the leg, on the suffering part of the body, to realize that the temperature is lower, and most probably the problem is vascular. So, and as a screening tool, it's really indispensable as a screening tool. Especially, we know that about 30% of the population are diabetics, unfortunately, and at least 30% of these diabetics, they have or they will have vascular problem. So, in case such a simple, very fast method is included into the screening process, annual or twice a year, a screening process of diabetic patient, a lot of early stage vascular pathology will be treated on time, not on the late phase, just before the amputation or even after the amputation. So I think it's the population-based and society-based value will be unbelievable. Yeah. Some other questions, comments, proposals? Donald, Dr. Reed?
I think it's fantastic what you're doing. It's just one other application I'd like to suggest that Zoran might want to follow up, is the idea of looking at mesenteric ischemia, because for the surgeons, the difficulty in knowing when to resect ischemic bowel and anastomose the bits together, this could be a fantastic help inside the abdomen, in the operating room. It could be used for colorectal surgery, where they have dissected the tumor away and tried to anastomose it, or should they not anastomose it? The applications are fantastic and very practical in the room.
Great comment. Thank you for that. Thank you for that. In fact, we have used the thermocamera several times during an intervention. You know, the long-lasting dispute, how much to revascularize. Is it one line all the way down to the foot is sufficient, or we have to revascularize all the three tibial vessels? So in this situation, like Zoran have shown, there is a quite good coverage overlapping between the angiosome and the data that the thermocamera can give us. So in case of a good collateralization, probably in a particular patient, one simple straight line to the foot is enough. But in case of lacking of revascularization and micro vessels and micro channels, probably in this case we have to be more ambitious and to continue the procedure. And we had such a patient. He came with a small wound of the toe, and we made anterotibial intervention with fantastic result all the way down to the foot. But unfortunately, he was continuing complaining, and the wound didn't heal. And 3 days after, we revascularized the posterior, and his toe was saved from amputation because of the thermocamera data.
Any skepticism in the room? It's always good to have, I believe.
Of course, we will search in the future much more precision, let's say, and much more, Anna already mentioned what we have discussed, standard conditions of taking the data. So we need standard ambiental conditions, distance conditions, temperature of the surface behind, so standardizing the way of taking the data. So this is crucial in order to have to be reliable and to have even this standardization will help in future trials, in future scientific data.
Yeah, and here what I would also ask is, what is the gold standard? So the first is a data set that you will feed to learn the algorithm to create it. Was this the compared to, so what's the golden standard reference? Is it the eyes of the like hand, or is it?
Yes, in fact, because it's a unique, there is no golden standard to compare with. So we are in fact creating the golden standard, and we were asking ourselves to compare one leg compared to the other leg, or only to compare one territory of the leg toward the other territory of the leg. And probably both are important. So we need comparative data between the arms, between the legs, and within the organ that is examined. And in fact, we have discussed with our senior angiologist, Professor Gruzinski, and he was asking me about numeric data, about numbers. He wanted to have numbers, but in fact, for example, in a CT, we don't have numbers. On the CT, we see very well where is the occlusion and where is the lack of perfusion. There are not numbers there. It's just a picture. And here is the same. In fact, when you see, for example, again, the patient with Leriche syndrome, you probably saw, I will show on mine, the red part was around the pelvis because this is the source of collateralization. And this is a huge collateralization trying to give perfusion to the legs because of the Leriche. And this collateralization and the huge difference between the pelvic part and the legs color, in fact, it's more than obvious that there is a problem there. Probably our colleagues, they have experience with, in fact, they are involved into this database gathering. And we have, don't be upset, we have spoken about the skepticism. All we were extremely skeptic, including I myself. I was extremely skeptic. It's just a simple camera, utilitarian camera that is not, it's not a medical device. How can I believe that this can give me reliable medical data, medical information? Which way? Evidently, the only way is to combine the artificial intelligence to the high resolution camera. We still dreaming to have higher resolution camera, to have moving pictures, moving objects. The heart is moving. So we are dreaming to have the possibility to examine moving objects like the heart. There is a small publication, by the way, showing the difference in surface temperature in patients with cardiogenic shock. There are only 2 or 3 cases in this publication, but more than obvious, other cardiologists in the world also are thinking about this possible application.
So are there any other questions? Yeah, please.
Yeah, it's an amazing technology, and I think it has a prospect of getting us through screening and everything in the future. Certainly in diabetic patient and high-risk patient, instead of doing all the annual surveillance for those patients, a simple technology like this will provide us the answer. Have to say, slightly disappointed that you're planning to take it off the mobile phones or of the iPhone. Basically, all of us now, we can go to remote clinics or and having a technology that you could take in your pocket all over the place is much easier than having you kind of centralizing it in one place. I know the standards has to be the same, but I think even it gives you some answer. Or even if you want to go and do a second review in the clinic. The second thing is, again, in the telemedicine era, and whether this could be used as to be connected with another device remotely, so you could have the answer remotely, whether with the patient phone or another physician's phone. Is there anything that would happen like that?
Yeah, thank you very much, great Max. So essentially, we're not removing the mobile phone at all. I mean, we are replacing it for a moment, so to say, until we develop fully the algorithms. But essentially, our vision, especially for the next phase of the project, is to have this mobility for, of course, remote patient monitoring, for monitoring of patients in remote areas in developing countries. And our big vision for, let's say, 10 years from now, or earlier, hopefully, to be within the home, within the premises of the patient, actually. To have this device, for example, in the bathroom, to scan your body before you jump into the bathroom, and to tell you whether or not you should visit a specialist based on what has been seen on thermodynamics. So we are not removing the mobility, we're just, let's say, this is for the first phase until we develop fully the product, until it's fully certified by the regulatory, and the regulatory actually allows us to, of course, make it mobile, make it within the premises of the patient. So that's essentially our plan for the next, let's say, few years.
Okay.
Yes. So my question is regarding this thermocamera. How deep actually it takes information only from surface, from skin surface,
Yeah.
or maybe it takes from the deeper tissues?
So
Because the temperature is different from the surface and from the deeper
Yeah,
tissues.
it's completely different, that's correct. Essentially, the deeper tissues, they impact the surface temperature. So if you have inflammatory process within the, some deeper tissues, they may impact the actual skin, the local skin, the skin region that is within this issue. And using our proprietary algorithm, we are kind of amplifying the result that this camera provides to the point of having very high contrast in dynamic range within this region, so that this region is very contrasty and very easily detected by even a person. So to answer your question, there are limitations with the thermography, that's correct. We're kind of going around them using the technology at our hands.
And I guess you're developing algorithm to make more accurate
Exactly.
measurements.
Exactly. And by the way, I wanted to mention, because there is, most of the people are conservative about thermography because it's seen as not accurate in terms of measuring absolute temperature. That's correct. Actually, this thermal camera that I'm holding is like 2 degrees offset from the real temperature. However, it's actually very accurate to the point of 0.001 degrees in terms of the relative temperature. So if we're measuring the difference from this region to this region, it will be absolutely accurate. And this is what we're analyzing. We're not analyzing the absolute temperature, we're analyzing the relative differences.
Discrimination. So the discrimination is perfect. Thank you very much for all the data.